introduce our next speaker, Dr. Chris Ames, who really don't need any introduction, and he'll give us a talk on AI and predictive modeling. Thanks, Chris.
Well, thanks, Lee and Lionel, for the invitation. In the next 20 minutes, I'm going to try to update you on where we are in terms of data and what we're doing with AI, and really also what we're doing with our data hunt for new variables that we think are going to be important, and trying to make those new variables accessible to surgeons, at least to acquire and hopefully in the future to start to implement in your decision making. And I also want to touch in the beginning a bit on why I think this is so important. In terms of my disclosures, the most significant is I do work with Medtronic quite a bit on their intelligent data solutions program, and also in some of their business development. In case I run out of time, these are some of our recent publications in the area. We have a whole edition of the ISASS journal on AI and machine learning. And then these are some of our recent publications in epigenetic aging and new biological variables for prediction. So my career so far has been about 21 years as an attending UCSF. And over that time, I've seen really most of it has been a focus on what we put in patients, and maybe a little bit on approaches, and not so much on the why of what we're doing, but more focus on what I like to call the what of what we're doing. What devices we can put in. Like the best example of this to me is all the OLIF, lateral, anterior psoas, prone lateral. I can't even keep track of it all. And if you really take a step back, interbody grafting of the curve apex has never been shown to make a difference at all in adult scoliosis surgery. So any grafting above L5S1 has never been shown to make any difference in outcome. But yet this is a huge focus in med device. It's a huge focus in research. We continue to, I think, waste a lot of our time on that area. It's not just the medical device manufacturers, though, that really deserve some of the blame for this. We have grown up in an environment, and if you look at the SRS or NAS, most of what we have on the podium, even now, is correlation analysis and R-squared data, even coming out of the major registry groups, and Barron's here from HARMS. We're really guilty of not moving and evolving in a way and moving toward large variable systems and predictive modeling. And I love the comment earlier about the predictive modeling for osteomyelitis outcomes. So the surgeons themselves need really a check as to what we're doing and how we're approaching research. And a great book by Simon Sinek is to start with why. Whenever we approach a new problem, we should take a step back, really survey the major problems that we have and what are the best approaches that we can utilize to solve those problems. Well, let's together collectively put a new set of glasses on rather than move beyond the R-squared, move beyond just the registries and what we have in the data and what we can put on the podium, and realize that we are essentially, in adult scoliosis world, we're surgical geriatricians. Most of our patients are over age 60. The most rapidly growing area of this is the aging population. It's the over 65 and 75. This is the most rapidly growing area of our patient population. And so many of the solutions that we have to develop probably have to do a lot with aging and understanding the aging process. Okay, the other part of why is how have we been doing? Is there really a need in this area? If you look at the progress we've made, we've been approaching patients with a lot more comorbidities over the years. We've made some impact in terms of mechanical complication, but a lot of the complication rates we haven't really been able to decrease very much over the last decade. And definitely we haven't made much progress over the last 5 to 8 years. Despite all the prone lateral, the trans-psoas, the OLIF, we're not moving the needle in terms of how we're treating these patients and their outcomes. And this is a major problem. If you just do a comparative assessment to hip arthroplasty, for example, those guys are doing a great job. They're about 3.4% revision. They're taking a lot of this, if you look at it as a business opportunity, they're treating the geriatric population. Their patients are not being revised. They have a huge lift in their HRQOL. In adult deformity, our revision rates are 20%. So if you're the CEO of the US healthcare system and you're trying to decide where to spend your money, you're going to put more of that money in a procedure that's getting a 20% revision rate, probably not long term. So I talked before about the focus in medical device on something we're putting in the patient. And we need to evolve beyond trying to do development programs around more multi-axial pedicle screws. And I participate in those as well, just like many of us do. But that's really not going to move the needle very much in the outcomes. We're doing very aggressive surgeries on these patients. We need to focus much more on the patient substrate. A good example of that is just look at the massive bone biology market, to take a pause for a second. Think about all the graft-on and demineralized bone matrix. It's a $1 billion market. No work has been done at all in trying to datafy the patient bone substrate. What bone cocktail should you use in which particular patient? No idea. Let's just make more demineralized bone matrix and try to sell it, right? But probably a lot of the variability in that outcome has to do with the patient's bone biology, and we haven't really dug into that. So medical devices realized, at least some of the leaders in med device, and you guys probably know who they are, who are forward thinking and looking at new imaging strategies and things like that. They've decided they're going to transform medical device from something you put in a patient to a data company that's going to acquire data and then make solutions based upon what the direction that data is moving them in. And we as surgeons also need to collaborate and cooperate there, move our research from something that's easy to do, like an R-squared, to something that's difficult to do, to build predictive models off of large data sets. It's much harder, right? Much easier to put an R-squared up on the podium than to spend 10 years acquiring data and make one predictive model. That doesn't build academic careers very easily, right? But yet, that's probably where things need to move. And this is one of the problems. It's not just complication rates, but it's also the fact that on the front end, our outcomes are all over the place. And the patients are very difficult to differentiate between who's going to have a good outcome and who's going to deteriorate. This spider web plot is actually the outcome of every patient in the North American and European registry. And you can see it's all over the place. Some patients had a huge lift in their disability scores. Some patients deteriorated, and we can't tell them apart on the front end. So a lot of the innovation is going to be having to tell on the front end before we pull the trigger on these surgeries who's going to improve and who's going to likely deteriorate without the bias, and I'll talk about that in a moment, of surgeons. A lot of us like to think, okay, well, this doesn't really apply to me. I'm such a good surgeon that I can take anyone and make them better. Well, if you look at the variability in outcome driven by surgeon alone in the ISSG and ESSG, the variation is about 2% in terms of how patients do. At benchmark levels where everyone's very experienced and practices at major deformity centers, who operates on the patient doesn't seem to make that much difference. It's more than that. So how do we go about this? Well, we can learn a lot from what's gone on in cancer big data. And I'll come back to that at the very end of the talk in terms of the future direction. But cancer has spent a lot of money on building large genetic registries, large patient registries, in clustering patients to try to figure out on the front end who's going to most benefit from a given intervention. Usually these are chemotherapies, but they're also just neoadjuvant therapies, combination therapies, immunotherapies. And it requires a very extensive datafication of the patient. That's why cancer's done such a good job in the US and worldwide war on cancer, is because they've datafied the patients and placed them in accessible registries and done this type of large-scale data research where they're not publishing R-squared anymore. They're publishing much more comprehensive analytics on patients. The modern reality at my institution of daily cancer care is when we do a biopsy on patients, when we resect like chordomas of the sacrum, like this case, these patients all get a UCSF 500 panel where every gene that's linked to responsiveness to therapy, to recurrence rates, to novel therapies. We have some chordomas that are actually getting interventions that were previously used for bladder cancer or osteosarcoma. based upon what they're uncovering in the UCSF 500 panels. This is a completely new paradigm shift. You would never know that certain cancers have certain mutations and would benefit from certain chemotherapies without doing the genetic analysis. In a similar way, we probably don't know which particular adult deformity patients are going to most benefit from certain types of interventions or non-intervention, no surgery at all, without doing a deeper dive into their inherent genetics. So we started about 6-7 years ago in the ISSG, ESSG with clustering. To compare sort of how the human versus the machine looks at the patient, on the left is how the typical informed surgeon of today might look at the patient. Give them a frailty score, comorbidity score, bone mineral density score, but we can't look at the patient the way the machine looks at the patient. On the right is a graphical representation of clustering analysis done with unsupervised machine learning, meaning it's not driven by the surgeon, it's driven entirely by the machine using high variable systems to classify the actual real number of different types of patients that we have. And beyond that, beyond saying basically you have 3 or 4 or 5 different types of patients, what the machine does is it's able in real time to say these are the patients most similar to the patient in front of you. What does that allow you to do? As humans, we can't remember 10 most similar patients to the one that we just treated and see how they did, but the machine can say this is how these patients were treated around the world by surgeons in Bordeaux, by surgeons in Barcelona, San Francisco, et cetera. You can see how those patients did, you can see the complications they had, and you can learn from it as a human. So machine learning goes both ways. It doesn't just go from the machine to the human. It also goes from the human to the machine. We learn from machine learning as well, and I'll show you an example of that in a moment. So we built an ASD classification that was actually based on risk and benefit. To me, this is much more impactful than an adult spinal deformity classification based on an R-squared. That R-squared has now gone away with more data, and I'll show you that as well. But this is based real-time risk-benefit, how patients are going to do, and what their likely complication rates are going to be. The problem is it's less accessible because, again, it's based in machines. It's not as easy as throwing up the Schwab classification and saying, look how easy that is to apply. The other thing that can be done with radiomics-based spline matching is this type of feature matching. This is something that's being worked on by one of the companies, but they're going to be able to go into 10,000, 20,000, 30,000 patient radiographic databases and immediately do a fingerprint match, pull out the 10, 20 most similar patients just based on radiomics feature matching, and show you those patients worldwide or show you those patients that you operated on in the past through this type of feature matching. This is something we cannot do as humans. It's beyond our capacity to do this, and this is going to be available in the next couple of years in your clinics. Well, you could argue that a surgeon like Dr. Lenke, for example, or some of our master surgeons like Chris Shaffrey here in the audience, maybe they don't need all this. They have like a lifetime of judgment. They have 30 years of operations. Maybe they don't need, this radiomics feature matching, but they have a major problem that they would admit as well. And that problem is bias. These tables are actually exactly the same size. If you measure them, had my son do this, they're exactly the same diameter, or exactly the same measurements, and if you measure them out, it's just our eyes that look at them differently. And if you think of yourself in the clinic looking at a particular patient, you may look at those patients in quite a distorted way based upon your last worst complication, or a patient that did exceedingly well, that was very challenging, and you think, oh, I'm going to be able to do that again. I'm going to be able to recreate that victory in this challenging patient, and that patient does extremely poorly, and this is our inherent bias. A great book on this is by Daniel Kahneman, a famous economist, on noise and bias. And this is something that even the master surgeon has. So this is where enabling technology and data can make even the master surgeon better. Well, you need proof of that. Here's a great proof. This is a study I did with Ferran Police in Barcelona, where we sent difficult cases around to the top surgeons in ISSG and ESSG. We asked them, what do you think is going to be the 2-year complication rate on this patient? And the surgeon estimates were anywhere from 1 to 100%. So that's not very helpful, right? And these are surgeons with 10, 20, 30 years of experience. These are not inexperienced surgeons. So there's tremendous variability. So we built risk calculators. And we enter demographic, radiographic, disability information, just a way of mapping the patient's data. It's incomplete. And the next part of the talk, I'm going to show you where we're going with this. So we built these calculators. We can predict with about 70 to 80% accuracy, depending upon when we predict the complication. And we can predict with about 70% accuracy the outcome based upon what outcome variable we're looking at. Mental variables are more difficult to predict than pain, for example. So that's where we were as of about 2 to 3 years ago. We started adding more data. We added more patients every year, 500 patients a year from ISSG and ESSG, and we found that we weren't getting more accurate. Everyone was like, okay, you need to add more patients to make these more accurate. It wasn't working. What that told us was there's either variability in the system that we're never going to be able to overcome. There's chaos in the system, so to speak, or we're not correcting the appropriate variables. And so now, the last part of the talk, I want to take you through what I think is going to be the new data environment of the future. And some of these are going to pan out and some are not going to pan out, but things are really evolving in terms of how we're going to process patients in the clinic. It's not going to be another frailty score. If you look at just at ISSG, my gosh, ISSG must have published 6 or 7 frailty scores. Everybody wants their name on a frailty score. Frailty score was developed for complication prediction. It's not going to impact or lift our care in any significant way. It's not going to be a correlation analysis on the podium. It's not going to be another classification. As you start going down this data into this data deeply, it's a rabbit hole. And unfortunately, it's complicated. It's everything taken together. Every variation in the patient, variation in the surgery, the patient's goals, and it's an inconvenient truth to think that this is going to be a simple solution. It's going to involve us all putting on different glasses and looking at things in a different way, including the way we do research. Let's look at Edmonton Frailty, for example. Everyone said, you need a frailty score to better characterize the patient. Well, Edmonton Frailty only applies to about 4% of the patients in our complex deformity data set. So it's not going to give us predictive ability. So we developed an ASDFI, an adult deformity predictive score. It's a frailty score. That was built to predict complication. We have that already. It's a predictive review of systems, and it works. It relates to complications. But it doesn't give us a comprehensive analysis of the patient's physiology. But it does work in one way. One thing that we wanted to do, as I mentioned at the outset, was to begin to differentiate patients on the front end. This was a study done by Aaron Clark, where he applied the ASDFI to the minimally invasive population. We saw when we looked in the literature that we weren't seeing a tremendous difference in patients treated MIS versus open at 1-year follow-up. That was the background. When we applied an ASDFI screener to the patient, a frailty score, we saw that patients that were frail that were treated MIS did much better in terms of a lower revision rate. So by applying a filter of more advanced data based on multivariable classifications, we're able to differentiate on the front end who's likely to do well with a minimally invasive versus an open procedure. This is kind of like the lowest hanging fruit. Well, we want to develop this further, and I'll show you it's going to be sort of a multimodality approach. One is we're going to have to rethink the way we look at BMI. BMI is not very accurate, and we're going to be moving from BMI, I think, in the future, where we assess patients like this who are quite cachectic, right, to a patient like on the right that merely has myosteostosis, muscular wasting. They have fatty infiltration of the muscle. They're not underweight, but that patient qualifies as quite sarcopenic based upon muscle quality. So how can we datafy this? We datafy it using a machine called the InBody 970. It's in clinic. It does real-time body composition analysis. We have one at UCSF. And the key predictive variable utilizing sarcopenia screening is the extracellular water to total body water ratio. And when that is above 0.39, that predicts a patient that's quite sarcopenic. This is a new way of assessing these patients. It takes just a couple minutes to do this type of sarcopenic screening. Another is going to be re-envisioning the way that we look at patients' alignment. and their activities that we're trying to estimate in terms of their ability to improve after surgery. So it had all been previously static alignment, right? Let's look at this for a moment and take a little bit of a deeper dive. When we look at the SRS activity score, which is a subjective score, versus a 4-meter walk, there's nearly no relationship. So what patients say they're doing versus how they're actually performing in a gait analysis or a walking test is quite different. So what really impacts HRQOL change after surgery? Well, this is where machine learning taught us something. So we, a few years ago, tried to predict what was going to be the ideal standing alignment for a patient, because we could predict a lot of other things. We could predict their post-op ODI, we could predict their complication rate. We thought we could go to the machine and say, predict the ideal standing radiographic alignment. And the machines couldn't do it. And this really tells the story. This is where we learned this fact from the machine learning analysis. The reason they can't do it is because the standing sagittal alignment, the post-op standing sagittal alignment, is nowhere in the top 20 variables of what drives outcome. This was something we learned from the machine. I think that point can't be overemphasized. Sagittal alignment is nowhere even in the top 10. It's number 12 and number 17, and it's all pre-op. It's all pre-op alignment, nothing to do with post-op alignment in driving the outcome. So we went back. We learned this from the machine. We went back to the data sets, and we said, what is the real R-squared now in larger amounts of data for outcome? And we found that actually pre-op sagittal alignment accounted for about 10% of what was driving that patient's disability score, and post-op, it was about 5%. So this was a paradigm shift that we learned from machine learning, trying to predict something. This is why this paradigm shift is so important. Look at this. So how much of your day do you actually spend just simply standing? A very small amount of your day. And yet standing sagittal alignment was the very basis for all of our adult deformity classification. But that's actually not what we spend most of our time doing. If you say, okay, well, we spend a lot more of our time walking, well, look at the importance of sagittal alignment in walking. It's the lowest ranked impact score in terms of what drives your walking speed. Number 1 was actually cognitive ability, and then number 2 was leg pain. But sagittal alignment was nowhere even in the top 10. So in our clinic, we've moved toward digitized gait assessment. This takes about 20 minutes. We use the Movella gait assessment tool, which we learned from Aaron Clark's wife, who does a lot of, Doris Wang, who does a lot of our movement disorders. And we now assess every patient and digitize their gait. So every patient we enter into a complex, the CADS database, for example. We do a comprehensive gait datification on these patients. And this allows us to quantify their extensor muscle strength and their movement. We do post-op gait assessments. Again, this takes about 20 minutes. And we can even classify their pathologic gait. This patient has a Trendelenburg gait from gluteus medius weakness, post-op. And when patients say, okay, how much am I going to be able to bend after surgery? Well, this is a post-op patient. We can quantify these T10 to pelvis, these T4 to pelvis, and we can tell them, once we have enough data, we can predict how much they're going to be able to bend after surgery. So we moved from standing sagittal static alignment to gait. Why did we do that? Not only is it probably more impactful, we spend more of our day walking, but it's going to give us so much useful information to predict outcome and function, right? So we're acquiring data for prediction. The next area where we moved into this is in radionomics. So if you follow the radiology literature, and I recommend if you're, especially there's so many young people here with embarking on careers in academic surgery, the best thing you can do to improve your ability to really move the research forward is to read in alternative fields. So if you want to read in the radiology research, it's all about radiomics now. And one of the things they're doing is able to quantitate visceral fat versus muscle ratios. They have actually established age-specific norms for the amount of muscular degradation and fatty infiltration that occurs. And we can start to leverage this as surgeons trying to do prediction and clustering on our adult deformity patients. Some of this is going to be built into just the Siemens software or the PACS software. You don't have to have anything special to do this. And this is going to help us to identify those patients that cannot be helped, for example, and patients that have very severe myasthenosis. This will be correlated and related to the sarcopenic assessments we do with the InBody 970. It's already being used to do outcome assessments in metastatic disease in tumor for spine tumors. So this is coming to the adult deformity world very soon. And then finally, I want to touch on an area that we've been very active with, which is in aging. We started out using, because we realized we were essentially surgical geriatricians, as I mentioned in the beginning, and there was a lot of aspects of differential aging that we were really just barely touching on in these patients. We couldn't tell them apart on the front end. So we went and first looked at telomeres. Why did we do that? Because Elizabeth Blackburn, our collaborator, was at UCSF, and she discovered telomeres and won the Nobel Prize for that. We found that telomeres were highly predictive of major complication rate at 90 days, but this was a small pilot study. The deeper we got into it, and in talking to more and networking more with the aging literature and researchers, they said, actually, you should start working more in epigenetic clocks. So the field is moving away from telomeres to more methylation-based aging, especially the pheno-age, which was developed by Steve Horvath, and then and Grim age, which actually predicts mortality, and then third generation clocks, which are the actual instantaneous pace of aging. And that's a clock called Dunedin Pace. This is the one we recently published on in terms of a preprint utilizing Dunedin Pace to predict risk of 90-day complication. Dunedin Pace was developed out of a large cohort study of 1,000 patients. They followed 50 years in New Zealand for the development of comorbidity. It's sensitive to things like caloric restriction. There was a large trial called Calorie, which showed that you slowed the instantaneous pace of aging with caloric restriction. And when we look at the instantaneous pace of aging in our population, of adult deformity patients, we found that the patients that had major complications were on average aging 13 months per calendar year versus the patients without complication that were aging normally about 12 months per calendar year. Why did they spend all this money to follow all these New Zealand patients for 50 years? You can imagine the cost of that study. Because it's a biomarker of interventions, pharmaceutical and otherwise, for anti-aging therapy, right? So they want a biomarker that they can then use. They give a drug, an anti-aging drug, and they can follow the impact on the biomarker because it's very difficult to tell otherwise how fast someone's aging. But we can use this as surgeons to measure the impact of prehabilitation, put somebody through an exercise program or some type of diet program. It gives us a marker that we can follow. The other interesting thing was that epigenetic age did not equal disability. It was quite a distinct entity from purely the disability measured by HRQOL. The other thing that these scores can do is you can train protein-based scores to epigenetics. Why is this important? Because it's just like hemoglobin A1C. Proteins vary significantly throughout the day. But using elastic net regression, you can map protein scores to methylation-based scores, and these are much more stable. So this is probably, in terms of markers, this is where we're going. Just to finish up, we're going to incorporate all of these new variables into our clustering analysis that we do over the next several years. And then we're going to move very substantially away from HRQOLs, I think, into the dawn of sort of digital phenotyping. There are now a bunch of startups that have developed methodologies of pulling everything from activity functioning to social functioning, the number of texts, the number of calls. They can do all this in a de-identified way to create a digital phenotype of patients that can be better used to track other outcomes across diseases. We think that the answer in the future is going to come in large part from biobanking. We started at UCSF in neurosurgery, and we're expanding this in Lekos Theologis, who's here, is going to be working with us as well. We started a tissue biomarker group, which is UCSF, OC, Hopkins, WashU, Rady, and the European Spine Study Group, to collect all of these tissues that we encounter during surgery And hopefully in a few years, we'll have epigenetic clocks from muscle, spinal muscle, and paraspinal that they've already done for other diseases. And then we'll be able to build a large spine genetics and biomarker bank. We already have 100 patients fully tissued out and biomarkered out in just the last 6 months. So this is something that can grow very quickly. We hope to leave this as a lasting legacy for some of the younger surgeons here to play with in the future. It should be something that can grow to thousands of patients over the years, and we think a lot of answers are going to come out of that. Most importantly, probably the lowest hanging fruit is to develop a frailty modifiable score, the identification of a patient that can be improved and modified prior to surgery. So thank you guys very much for your attention. And I'll take any questions. I know I ran over, so maybe just one question or something.
Chris, brilliant work as always, and really terrific being steadfast in this. You know, in the 80s, John Costwick wrote all the chapters of the various textbooks on adult scoliosis surgery. And he was the first person really to take on adult scoliosis and spinal deformity. Are we going to get back to the age before Costwick where we weren't really doing adult spinal deformity surgery? Do you think this is going to drive that surgery down dramatically, or you know, how do you see this playing out over time?
I think just like with cancer, you know, we will be applying these expensive and risky procedures in the future to the patients that are most likely to benefit from them and that we're less likely to harm. And hopefully it'll help us to avoid the patient that we only made worse, especially in the sort of the twilight of their life when they're, you know, retired and they're trying to figure out whether to invest in this procedure for themselves and go through this huge operation, great risk. And there are still, unfortunately, those patients that we really just make worse or we condemn to 3 or 4 revision surgeries. And hopefully by a better understanding of the substrate, we'll be able to better apply the therapy. And that applies whether it's a drug or a surgery. As surgeons, we have not been very sophisticated in this. It's been something we've done a much better job in oncology and other fields.
Either we figure it out or the insurers or policymakers will do it for us. So
that's for sure.
Great work.
Great. Thanks very much.